let's move to the next topic, that is temporomandibular joint. Temporomandibular joint is the one between these two bones, temporal bone and the mandibular bone. The articular surface is basically the condylar process, the head of the mandible, and the mandibular fossa of the temporal bone. So these two bones are making the temporomandibular joint. It is an atypical joint and it is a synovial joint. And with synovial joint, you will read two additional words. You will read atypical and you will read complex joint. It is called complex joint because it has a disc in it. Any joint with a disc or a meniscus inside its cavity, it is called a complex joint. It is called atypical joint because the articulating surfaces over the mandibular fossa and the head of the mandible, the condylar process, those are not covered with hyaline cartilage. These are covered with fibrocartilage, and due to this region, not hyaline cartilage, due to this region, these are called an atypical synovial joint. Okay, let's talk about the ligaments. What things are giving it its stability? First, there is a ligament on the lateral aspect that runs from front to back, from the zygomatic arch to the back of the mandible. That is known as lateral ligament, lateral temporomandibular ligament. As you can see from the direction of the fibers, it won't allow the mandible to go to the back. Then there is sphenomandibular ligament. We just saw in the 3D model. It is coming from the sphenoid, spine of sphenoid, and it is inserting into the lingula of the mandible, and it is sphenomandibular ligament. And we are left with the stylomandibular ligament. It is not these two ligaments, the sphenomandibular and the synomandibular, they are not directly linked to the mandible itself. They are away from them, but they ultimately keep the mandible in its place. So this is the stylomandibular ligament arising from styloid process and running to the mandible near the inside of the angle of the mandible. So these are the ligaments, and it has, then the last thing that it has, it is the articular disc. In front, it is attached to the insertion of the lateral pterygoid muscle. Behind and laterally, it is attached to the capsule, and behind it is also attached to the mandible and even the temporal bone. Here the tendon is split to be attached here and here. So this is about the functions, the structures that are forming it. Let's talk about the movements. The movements, there are three possible set of movements. First, elevation, depression. Depression, elevation. Depression, elevation, going down of the jaw and coming up of the jaw. Then there is protraction and retraction. Moving the jaw front, moving the jaw back. This is protraction and retraction. And then there is side to side movement. This is basically gliding type of movement. So these three movements help us chew. Let's discuss which muscles are creating what movements. Closing of the jaw, elevation. There were four mastication muscles, three of them. Temporalis muscle, it was coming from here down to the mandible, and medial and pterygoid and the masseter muscle, they are moving the jaw up. So these three muscles are moving the jaw up. Depression, opening of the jaw. Normally speaking, it does not require any additional set of muscles. It just, you let go of the muscles that are present and jaw will drop. Gravity will do its work. However, when you have to work against a pressure, then you need to get the muscles below the mandible active. So the suprahyoid group of muscles that included the digastric, the geniohyoid, and the mylohyoid, they get active and they reduce the distance between the jaw and the mandible, jaw and the hyoid bone, and they depress the jaw forcefully. So this is about elevation and depression. Then there's protraction and retraction. Protraction and retraction, we talked about the direction of fibers of masseter and medial pterygoid. They will be having a role, and in addition to that, the major muscle that will be doing it, that will be lateral pterygoid muscle. That will be lateral pterygoid muscle. So lateral pterygoid will be the chief one, and medial pterygoid and masseter will have a helping hand in moving the jaw into front. And then we are left with retraction. Taking it back, retraction will be done by the horizontally running fibers of the temporalis muscle and deep part of masseter. You saw that masseter's fibers were running in two different directions. So the fiber of the superficial fiber was suitable for protraction, but deep fibers were running in this direction, helpful in retraction. And protraction, retraction, and there will be genoid and the same muscle, genoid and digastric, because the hide bone was actually behind it, so it is pulling the mandible towards that. So temporomandibular joint is moves like this, and we are left with side to side movements. These movements are done by the pterygoid muscles, medial pterygoid and lateral pterygoid. When one muscle contracts, it if lateral pterygoid left-sided muscle contract, they will move the jaw to the right side. They were like this. They pulled the jaw towards themselves, so they pull the jaw inside. The left-sided muscle will contract. They pull the jaw towards themselves, and jaw will go like this. And then this will contract, and this is how we go like this. We depress and side to side movement, and we go on chewing thing. So this is about the temporomandibular joint, and let's discuss the nerves. The Hilton's law, the nerves that is supplying this. Let's not discuss the Hilton's law right now. The nerve that is supplying this joint is the auriculotemporal nerve. It was coming from back of the mandible, moving from here and moving up like this. So this was auriculotemporal nerve that is supplying the temporomandibular joint in addition to the other things that it is supplying. And we talk about the dislocation of temporomandibular joint. Normally, the temporomandibular joint is very stable in the closed space. The closed space, this is the closed space, closed point. The mandibular fossa is fitting the mandibular head, and when the mouth is open, let's see, when the mandibular head will come right here on the top, and it will go like this. Okay, now in the normal position in the closed mouth, the head was snugly fitted into this fossa, and even if the lateral pterygoid muscle tried to pull it forward, it would have been blocked by this protrusion of the bone, the articular tubercle, because it was originally there. But when you open the mouth, when the jaw drops, the head comes to the tip of the articular tubercle. Now it is vulnerable. It does not have anything stopping it in front of it. At this particular point, when you have opened your mouth very big and the lateral pterygoid muscle goes to spasm, or there is a blow from the back, then what happens is the jaw moves front. The jaw moves to front. It moves all the way to here with the coronary process right here. See, it will move to this point, and when it move to this point, it is stuck now. When it tries to go back, the same thing, the same articular process that was protecting it from going outside, it will be inhibiting it from going to its normal location. So the jaw will get stuck. That is called temporomandibular joint dislocation. Some of you may have experienced this effect that when you open the jaw clicks. It is basically mandibular going front and back of the articular tubercle, and jaw may get, some people it does get stuck when you take a very big yawn and the mandible gets stuck there. And what you have to do is you have to put your thumbs on the teeth You have to push it down. You have to push it down that it comes down. It can go over the articular process and it can go back to the fossa in its normal position. And sometimes the muscle spasm is stopping it too much that you have to give the person anesthesia before pushing it down and pushing it back. So this is what temporomandibular joint dislocation. This is a summary slide from the last anatomy, and all of the muscles, rules, and the movements is summarized here. You can take a screenshot. So I will stop my lecture here. I will stop the live stream here, and I will continue to keep on recording, and you will find the recorded lecture in the album. So now from this point onwards, I have to discuss the temporal fascia, the parotid region, the infratemporal fossa, the temporal fossa, and the pterygopalatine fossa. These are the topics that I will be discussing from this point. I will be uploading shortly within few hours, inshallah. You can follow this in the album of the head and neck, and I'm getting off the live feed now. Thank you so much for being here, being live. If you have any questions, suggestions, feedback, please do contact us, and don't forget to support us. Thank you so much. Inshallah, see you in the next video.